All right. Well, thank you all so much. And I know there's still some people filtering in the back of the room. There are a few seats up front, and there's certainly some places to sit down here on the side. We won't tell the fire marshal. I'm really glad to be able to welcome you all to the second annual Puri lecture supporting lymphoma and lymphoma research. It's a real honor for us today to have the family here today. And for those of you who may not know the story, Mr. Puri was a gentleman that I first got to know in 2004 when he first presented with mantle cell lymphoma and had our standard treatment and did quite well for a long time. And then the lymphoma came back, and he actually received a couple of treatments that were a consequence of some of the research we did here at Emory in terms of clinical trials and the ability to get these new treatments that didn't exist probably 15 years ago. But more so than the technology and the treatments and the science, which you're going to hear a lot about in the coming moments from our distinguished lecturer, I always say that every patient teaches me, or the physicians, a lesson. And we always learn lessons about strength, about dignity, about courage. What I learned from Mr. Puri over all those years that I was fortunate enough to know him was how important family is, and you can see they're represented up front here today, and how important work is. He was very dedicated to his work, and that's sometimes a hard message to get across. I have two small children, and sometimes it's hard to get that message across to them. But his dedication to his work was really amazing. In the middle of hyper-CVAD, aggressive chemotherapy, he was still going to the office, traveling, doing things that were a part of who he was. And on top of all that, he always remembered and was telling us stories about his family and ways that they had touched his life as well. So I think those lessons are really important. It's the human side of what we do. It's in many ways more important than the science side, but we need the science to be able to sustain the human side. So I'm very privileged to stand here today and introduce Dr. Puri, his wife, who wants to say a few comments as well, and whose generous gift is what allows this kind of interactions to really occur. We're incredibly grateful to the family for creating this lasting memory in his honor. And I can tell you, and Dr. Williams will probably tell you as well, how busy the last day and a half have been really trying to build the program as a consequence of that donation. So, Dr. Puri, please come up and say a few words.
Well, thank you, Dr. Loniel. And I'm a nervous speaker, so I'm going to read, so forgive me. So good afternoon to all of you. I'm Ridula Puri, and I'm the wife of Surinder, whose memory we honor today. I want to welcome you all to the second annual Surinder Memorial Lecture, and to thank you for joining us today. I would like to extend special thanks to Dr. Michael Williams. It's a real pleasure to have you here as a clinician of your caliber, and to honor Surinder's memory here for us. This coming Sunday, Surinder would have been 79 years old. And going into this weekend, I think this is just such an event, just starting off our weekend of his birthday celebration for us. As Dr. Loniel said, Surinder's diagnosis in 2004 of mantle cell lymphoma was a devastating and a frightening event in our lives. And after researching all of our options, we settled on the team at Winship, which was led by Dr. Loniel for him, to treat him, and it was the best decision I think we ever made. The expertise and warm care of the Winship team and Surinder's own fortitude gave us 12 wonderful years of his life post-diagnosis. And those years he remained an active professional and enjoyed his passions for travel, food, art, music, and whatever made fun for him. We are very aware that we were lucky and privileged, and that Surinder had access to cutting-edge treatment through Winship, which enabled his treatment to evolve with research and emerging theories about mantle cell lymphoma. And we know that the cases of mantle cell lymphoma and other B-cell lymphomas are increasing. Maybe it's more identified in numbers. And not every patient is as fortunate as Surinder was. So in establishing this memorial lecture in his honor, it is our family's mission and humble goal to be able to bring together the best researchers, clinicians, and pioneers like Dr. Williams to Winship and enrich further this very academically and clinically rich organization. We hope to catalyze collaborating and cross-cutting research opportunities by amplifying a community of practice, sharing, and investigation. And through sharing these lectures online, we hope to disseminate the ideas and information shared here widely to others who may also benefit from it. I would like to give special thanks to a few people here at Winship for working with us to establish and administer this lecture, Dr. Loniel and Dr. Flowers for their leadership and friendship, and to Barbara and Jack for incredible job of organizing the event and patiently fielding many inquiries. Finally, I want to end by saying Surinder was an immigrant. He had achieved almost perfect harmony between his Indian culture and his adopted American home. He made significant contributions in every aspect of life to his community and was admired by all who crossed paths with him. He was a perfect model of an American citizen, which he proudly became. He was cared for also by immigrants and children of immigrants. And there are millions of others like him and like them, many in this room, and it is my conviction to continue progress, both as a society and scientifically, we need more and not less of us. Thank you.
Wow, that was, we have that somewhere on tape, I'm sure. So thank you very much. And what I'd like to do now is introduce Dr. Chris Flowers, who's the leader of our lymphoma program, to introduce our distinguished guest.
Well, thanks, Sagar. And like Sagar, I'd like to give a wholehearted thanks to the Puri family for their generous gift for putting on this lecture series. And first, I'd like to start off by giving a little bit of follow-up on last year's lecture that was given by Ash Alizadeh and this collaboration that was started. Thanks to that collaboration, we've now built upon both last year's lecture and those meetings to have an ongoing collaboration with Ash Alizadeh, including work by Jordan Goldstein, who's a medical student here, Priyoti Islam, who's an Emory resident that's working here, and Ashley Staten, who's one of our fellows that are continuing that work from last year's lecture series. We have the great privilege today of having Mike Williams join us. Mike is the Byrd S-level professor of medicine and professor of pathology at University of Virginia School of Medicine and the chief of the Division of Hematology and Oncology and director of heme malignancies at UVA. Mike first began his training at University of Cincinnati, where he received his medical degree and then got a Master's of Science from Harvard. And then after that became a Virginia lifer, doing both residency and fellowship and staying on at the faculty at UVA. He's made numerous scientific contributions, many of which he'll talk about today, from the very founding and our understanding of mantle cell lymphoma to many discoveries that have led to some of the therapies that he'll talk about later on in the lecture. He's been on scientific advisory boards for the Lymphoma Research Foundation and as vice chair of the Eastern Cooperative Oncology Group, where I've worked very closely with him in both of those endeavors, and has been chair of the board for the hematology specialty for the American Board of Internal Medicine, which he's done for the last decade or so, leading us into the future for how practice of medicine should take place in hematology. And I think notably, he's been one of the leaders of the European Mantle Cell Network, which is actually surprising that Charlottesville is part of the European Union, which may be a distinct advantage that you'll have in the future related to some of the comments that Dr. Puri mentioned. So without further ado, we'll bring Mike forward to talk about his work in mantle cell.
Well, thanks very much, Chris and Sagar, and my thanks as well to the Puri family. And If I may, I have to say that your comments at the end of your introduction really struck a chord, and I think reflect a sentiment that so many of us feel, and it's a different time we live in now, but I have great confidence, I think, as your husband did, in this country, and the real fiber that runs through, I think, the vast majority of us to embrace those who are willing to be here and move here and contribute here. And so this, I think, just becomes an even more poignant memorial in his honor. So thank you for those comments. So it is, indeed a real privilege to and an honor to present this lecture. I had the privilege of a pleasant evening last night with the Puri family, and to get to learn about them. And I have to say, as just to echo Sagar's comments, that when you suffer a loss such as they did, it's a challenging thing, and we all respond to those moments in different ways. I think responding in such a progressive and thoughtful and generous way to allow the opportunity for someone like myself to come here, spend 2 days meeting with this group. So we already have some collaborations that have initiated, but it's been a thrill to hear from so many colleagues here about their work, to see places that we could interact. I'll try to comment on a couple of those as we go ahead. And Chris and I both have some very bright junior faculty in our groups that are starting to work together, and this gave us a chance to think about, as you said, how to catalyze that further. So it's just a real treat and honor to be here. So what I want to do is to touch base on a few things that I was asked to go over today. One is a little bit of history, which for somebody of my advancing, clinical experience, if not years, gives me a chance to go back and revisit some of the early work in defining mantle cell lymphoma. I'll talk briefly about sort of the current diagnosis and pathogenesis, very briefly about current approaches to therapy, because A, there's a lot going on there, and B, it's fast moving. So I thought, rather than dwell excessively on that, I want to spend a little time in the latter part talking about some of the novel treatment and agents, one of which Mr. Puri benefited from, ibrutinib, and some of the new approaches that we can use to further, extend and improve the outcomes and survival for our patients with mantle cell. All right, so the history. So I guess you could say, what's in a name? Like, why does it matter if it's centrocytic or mantle cell or whatever? But, unless you have in medicine, no matter what your area is, unless you're able to specifically drill down, define, describe an entity and put some boundaries around what that is, then it's hard to scientifically address what you can do about that particular disease to improve outcomes and to move it forward. So the classification has been a moving target over the last 75 years, going back to the early 1940s, when there were about 4 lymphoma entities described, things like lymphosarcoma, et cetera. And then in the 70s, when we first started recognizing things like T cells and B cells, and having some ways to identify those different cells in these morphologic types of lymphoma, then you could start to parse them out and break them out into more detail. And I'm going to particularly talk about, on the right there, Dr. Karl Lennart from Kiel, Germany, who defined what's called the Kiel classification. Ultimately, these various approaches were merged into the real classification, which was the revised European American Lymphoma classification that Nancy Harris led, and then now into the WHO, which is sort of the definitive Bible of all hematopoietic malignancies, leukemias, lymphomas, myeloma, et cetera. That was last updated in 2008, but another edition will come out later this year. So it's fascinating to me. I'm sure there are some pathologists in the room. I've always been impressed that pathologists have such keen pattern recognition. They recognize cellular arrays of disease. And Professor Leonard, largely on morphology, started to define differences among lymphoma subtypes, and then combined that with immunologic definition to create this Kiel classification. And in particular, this subtype that they originally called germinocytoma, they subsequently called centrocytic lymphoma, because it appeared to derive from centrocytes in the marginal zone around the follicle center. So if I can, yeah, here's my pointer. So this is Professor Leonard in 1974, and on the blackboard behind him, you can see he's outlined this classification. So he, and here's centrocytic lymphoma as one of the subtypes of low-grade lymphoma. Now, Wolfram Clapper, who's in Kiel now, he's a hematopathologist there, provided these slides, and you can see a couple of things. One is that he recognized there were aggressive and indolent subtypes that included both morphologic and clinical types, that there was a biologic underpinning for this. Some were B cell, some were T cell, and that cell of origin was important. Were they centrocytes or centroblasts, et cetera? So this is sort of the Kiel classification is really the framework that much of this carried through into current classifications. So this was, when you look back at his archives, which Professor Clapper has done, so patient K was a gentleman born in 1905, and at age 63 was found to have this unusual immature lymphoid malignancy. Then there was this entity, something called a myeloid leukemia, which may have actually been the same thing, they just didn't have the marker studies to look at, and then later a small cell lymphosarcoma, and he died in 1972. So, oops. I don't want to do that. There we go. So, these are Professor Leonard's files. So, this was for those of you who are younger than some of us. This is the way the magic used to happen. So, 3x5 cards, you know, this is where we used to look up books in the library. So in this, he collected a series of cases that he called type K for his initial patient K, and here's a couple of them here that he called this type K. And this is the original patient K histology. So Wolfram went back, found the block, cut the section, so you'll recognize this is a not real well preserved, but a small lymphoid malignancy, and using current technology, it stains positively for cyclin D1 and has the 1114 translocation. So there's the index case. So again, you start to define entities, and then you can actually, you know, figure out what is their clinical course, how do they behave, how do they respond to therapy. So this is a letter from Professor Leonard to Steve Swerdlow. So Steve, as you'll see, was, we collaborated on these early analyses of what was called centrocytic lymphoma, and Steve had taken a particular interest in this lymphoma and spent time in the UK and wrote to, looking at centrocytic in particular, and so he wrote to Professor Leonard, who said that the first time they reported this was in a conference in 1973, and I mentioned some of the previous terms, and it was about 2 years later that it really was reported as an entity in the Kiel classification. So Steve pulled together a series of these in the UK, which really greatly expanded and refined kind of the spectrum of what mantle cell looked like. Some of them were more blastoid or immature cells, some were more small clefted cells. And then ultimately, so what happened between, I can find my pointer, there it is, between here and here in these years is that some of the initial molecular work, which I'm about to show you, further refined this as a real clinical and biologic entity, and it was ultimately renamed mantle cell lymphoma by this working group based on a combination of the immunophenotype and molecular markers, just as we do now for so many of our entities in lymphoma. So the other steps in the characterization were that in 1984, Carlo Croce, who was in Philadelphia at the time, was interested in looking for relevant genes by cloning translocation breakpoints in leukemias and lymphomas. And they had some cases that, one case in particular that was actually called a CLL. We now know in retrospect that was a leukemic mantle cell lymphoma. And they cloned a breakpoint on, from a translocation of chromosome 11 and 14 that involved, there was no known gene at the site, and it was translocated with an immunoglobulin heavy chain locus. So because there was no gene, they called it BCL1 for B-cell lymphoma 1. So no gene. They then cloned BCL2, which was the 14-18 translocation, and BCL3 and 6 so there was a whole series of these, but there was no gene identified at this locus, so it sort of was left aside. It was a relatively rare event, and other things were worked on. So we, Steve, because of this interest in centrocytic, knowing that I was doing some molecular work, primitive by today's standards, looking at clonality in B-cell malignancies, sent me some mantle cell cases, specifically because he wanted to look and make sure there were no BCL2 or c-MYC translocations. So I did that, and there were none. But I had this probe from Sugimoto in the freezer, and I knew that there were some similarities of centrocytic and intermediate lymphomas where there had been a couple of case reports. So I rehybridized those original blots with this BCL1 probe. And that led to this image. So these are 18 samples from these 14 patients, if you look at this here. And if you'll let me indulge sort of when I saw this, it's not like this is some grand discovery, but it was a fun moment because the autoradiogram was exposed, but it wasn't ready to take off. I wasn't ready to take off the films until the weekend. And the automatic developer for developing the film they didn't operate it on the weekend, cost savings. So I had to do it like in the old developer, things like that. And so I'm in the darkroom and I hold it up and I saw this and I thought, wow, that's pretty cool. So there's something non-random here. So we did some work and we published this. And one of the things that, of course, was apparent to anyone is that over a quarter of these cases had rearrangements compared with very few in other B-cell. And it was obvious that, well, gee, maybe if we can clone these breakpoints out of the lymphomas, we can find the gene that's been missing. So that led us to another series of experiments, finding multiple other breakpoints, but still no gene. And then I had a call one day from Andy Arnold, who had worked with Stan Korsmeyer as a postdoc. He's actually an endocrinologist, but he was interested in parathyroid adenomas. So one of the questions was, are they polyclonal or monoclonal? So knowing that he had worked with Korsmeyer and had done gene rearrangements for BCL2, he tested the parathyroid gene to see whether there were clonal markers. And what he found is that there was a translocation that resulted in a pericentric inversion on chromosome 11, and it made a breakpoint right next to a gene that hadn't been discovered before, and that turned out to be cyclin D1. And so there were multiple groups looking for the first mammalian G1 cyclin, and it had not been found, but this was it. And he called it PRAD1 for parathyroid adenoma breakpoint 1. Subsequently, it was renamed cyclin D1 or CCND1. So it was the first mammalian G1 cyclin. And I got a call one day from Andy Arnold, whom I didn't know, and he said, we think we might have the gene that you're looking for in lymphoma. And so he sent me PRAD1 breakpoints, which were about 100 million base pairs away from the original breakpoints we were looking at. And in fact, the breakpoints that Andy had cloned from parathyroids were exactly adjacent to the gene, but did not disrupt the coding region. They just dysregulated the expression by virtue of putting the immunoglobulin heavy chain promoters in there. So that was the BCL1 gene and cyclin D1. So we reported those breakpoints. We reported a PCR assay for the most common breakpoint. And then Andy's group, working with Nancy Harris, who led the real classification, they were making antibodies to try to do an immunostain for this. And they had one rabbit that had been injected that made an antibody that worked. There wasn't a lot of plasma, but they shared some of that with us, and Steve stained a bunch of cases and showed that essentially everything that was centrocytic or mantle cell lymphoma expressed cyclin D1. And what was interesting is that it was almost 100% of the cases. In fact, it was 100%, even those that didn't have a breakpoint. So either there were breakpoints we didn't know about, or they were expressed through some other mechanism. So cyclin D1 then became a hallmark, almost not specific, but it really almost a disease-defining marker for this lymphoma. And that helped, again, define this as a specific biologic entity as well. So here it is now. This is what we do all the time with diagnosing mantle cell, is to stain for nuclear cyclin D1, to look for the translocation fusion product. So that's become routine diagnostics. There are a number of targetable pathways. I'll talk about some of those. The survival, the median now is at least 6 to 8 years. It really, for many patients, is going out beyond 10 years with all the therapies that we have to offer. And I'll run through a few of those. So the typical presentation, it's got a preponderance in men, tends to be older in the 7th and 8th decades. Very common to have extranodal disease, especially the GI tract. People are often symptomatic, and there's a spectrum of morphology and cytology. So here's sort of the standard diffuse morphology with these small convoluted or cleaved cells. There's a nodular variant. There's a mantle zone variant where the centrocytes are expanded in this mantle zone around a germinal center. And we know that these things have a stepwise development. The cyclin D1 translocation appears to be, if not the early, it's certainly a very early event, but just overexpressing cyclin D1 in B cells does not transform them into mantle cell lymphoma. Cyclin D1 is typically not expressed in any B cells, so this is a gene that nature did not intend to be on in B cells, and when it is, unhappy things happen. But we know that there can be a long development, often years, where there's an earlier in situ phase, ultimately evolving to where it clinically presents as the typical mantle cell, and sometimes even transforms through markers that are now recognized into a blastoid or more aggressive subtype. So, as with many of our diseases, even though this is a fairly specifically defined entity, there's still a large clinical spectrum within that subtype. And that can be reflected in the proliferation rate. This is work from Andreas Rosenwald in Lou Stout's group at the NCI. So in this scheme, this is a proliferation signature for 20 genes, and the green means off, and the red means that these proliferation genes are expressed. And you can sort of split it into quartiles, and you can see some of these have a very low proliferation rate that correlates with a very favorable slow pace of disease, whereas these tend to be the blastoid, very aggressive cases. We don't do gene expression profiling on many of our patients outside of a study, but you can use a proliferation marker, Ki67, and those that are above 30% tend to have poorer outcomes than those with the very low proliferation, as you can see here. So it reminds me to take a moment and just comment about the fact that although there is this spectrum of disease in mantle cell, most patients will require treatment at the time of diagnosis, but it's well recognized now that there's an indolent subtype that often can be confused with CLL. So they have splenomegaly, a leukemic phase, often very little in the way of adenopathy, and many of these patients and others with a very low burden of adenopathy and asymptomatic can be managed like indolent B-cell lymphomas and just followed without treatment. There are molecular characteristics that I won't read through that also help define this indolent versus typical presentation. So, frontline therapy, switching gears into what do we do about these cases? Standard of care is really not established, so we don't have, unlike, say, the majority of cases of diffuse large B-cell lymphoma, R-CHOP is really a standard of care. whereas in mantle cell, it's not so well defined. It depends very much on the subtype of disease, the clinical presentation, the patient's overall fitness. As I said, you can watch and wait these asymptomatic quiescent types. For younger and fit patients, a high-dose cytarabine-containing regimen followed by autotransplant consolidation, and nowadays, as I'll show you in a minute, maintenance rituximab, based on recent information, as Mr. Puri had. That's certainly a very good standard of care, and I think that you have to consider that as your first line of treatment in anyone who is a transplant candidate. For those who are less fit, decline transplant, then there are a variety of options that can be used, including now an emerging opportunity to use non-cytotoxic therapy for these patients. So, how do we do better with this? How do we start to define response to disease, get surrogate markers to predict outcome? So molecular remission is certainly something that's being looked at in many cancers, but especially in lymphomas. So I wanted to walk through a little bit of work. This is mostly from Eva Hoster and Christian Pott, who do the statistics and the MRD, the minimal residual disease work for the European Mantle Cell Lymphoma Network. So different ways to look at MRD by multicolored flow, either 4 or 8, by using clonal markers detected by RQ-PCR, or by actually doing next-gen sequencing, where you can detect one malignant cell out of 10 to the 5 or 10 to the 6, so very sensitive markers. And in terms of sensitivity, here's the most sensitive molecular markers, 1 in a million, RQ-PCR about 1 in 10 to the 5. The flow methods are not as sensitive by a couple of logs. So we have the ability to do this. The question is, does it make a difference if you achieve molecular negativity on top of, say, clinical remission? So this is a conclusion slide from the European study of R-CHOP times 6 versus 3 of R-CHOP alternating with 3 of rituximab and DHAP, a high-dose cytarabine regimen, followed by autotransplant. And what they found is, if you just look at these curves here, this is the bone marrow pre and post-transplant in patients treated with R-CHOP, and here it is for patients who had the combination regimen. So you can see that with the alternating regimen, you had a much higher rate of achieving minimal residual disease. So theoretically, that should reflect a deeper remission. So does it make a difference in outcome? Well, the answer is yes. So regardless of how you got to MRD negative, CHOP or R-CHOP DHAP, if you were MRD negative, you can see that those patients had a much prolonged remission duration than if they were still MRD positive, where you see this continuous relapse rate. So some of these people are enjoying ongoing remission out 5, 6, 7 years. So MRD in mantle cell is the single strongest predictor of outcome. These methods are not yet standardized for routine use and for routine clinical decision making, but they're part of all the current phase 3 studies and phase 2 studies to look at depth of response. And the current US intergroup trial that's being developed will be MRD driven. So you'll get induction therapy. If you're MRD negative, then you'll go into, say, a maintenance rituximab, whereas if you're still MRD positive, they're going to ask the question about, do you need high-dose therapy, or can you just do, say, a consolidation and maintenance? So there'll be a randomization to transplant or no transplant. So an MRD-driven study. The Europeans are modestly chagrined. I presented that protocol at their meeting. So they've done all this work to develop MRD assays, but the US is actually probably going to be first out of the blocks with using a real MRD-driven therapy. So a little satisfaction there. Now the other way you can use this is that, so let's say you've got a patient who's post-induction, whatever you give them, they're MRD negative, just as we do with APML and CML. If you follow those folks and then they become MRD positive again, then does that give us an opportunity to do preemptive therapy, like do something much less toxic that can put them back into their deeper remission rather than let it progress to where they've got a clinical relapse and you have to use bigger therapy? So the Nordic group, who really have led the way with a lot of initially the high-dose Ara-C studies and others, so they looked back at their studies where they did monitor MRD, and if somebody became MRD positive, they got rituximab therapy. No chemo, just rituximab, and most of them, 87%, converted back to MRD negative, and once they got back to negativity, the average time from that preemptive was over 4 years of further disease control. So MRD gives us a way to identify people before they clinically relapse and to do something pretty simple to keep that disease in remission. So they found that there's a continuous pattern of relapse, so nobody appeared to be home free even out toward 10 years. There still tends to be recurrences, but if we can monitor them and get on them sooner before they relapse, then you've taken a disease, even if you've not cured it, you've controlled it, and theoretically they should be able to live to whatever age with their disease under control and not have this as the cause of their death. So one study I wanted to show you from ASH because I think it is practice changing and it's informative on a lot of levels. So the French group led by Stephen Legui and Olivier Hermine sort of took this protocol using the high-dose Ara-C as a backbone of mantle cell lymphoma therapy in a transplant trial. So these are younger patients, transplant eligible, and what they did was use, I think this was important, it's a non-anthracycline, non-cytotoxic regimen of rituximab plus DHAP, so Dex, high-dose Ara-C, and the P is cisplatinum, although almost nobody got cisplatinum in the study. They got carboplatinum or some oxaliplatin. So you didn't have as much renal risk. So virtually all people achieved a remission with that. Those who didn't got, I think, 3 cycles of R-CHOP, and then they went on to conditioning and transplant. Then those in remission post-transplant were either observed or they got 3 years of every other month maintenance rituximab. So the question is, was that beneficial? If you already had a deep remission from transplant, do you need the maintenance? I won't go through that, but here's the progression-free survival. So the red is the rituximab maintenance arm, and the blue are the patients who are on observation. Now, you can see there's a lot of patients still out here, even without Ritux maintenance, but that's a pretty impressive PFS for those who got 3 years of Ritux maintenance. And you can see, you can't read it in the back, so this is about 5 to 6 years of follow-up here. And there's overall survival, so very good for both groups, but we're looking at about a 90% 5-year survival with 3 years of maintenance rituximab. So their conclusions were that with this regimen, you had very high rates of complete remission, both before and after transplant, very good long-term disease control, and prolonged overall survival. And in fact, there was a survival advantage for 3 years of maintenance rituximab in this study. So certainly, I think, a very appropriate, based on this phase 3 data, with a large number of patients, it supports doing that. Now, shifting into some of the newer targeted approaches, I wanted to just remind you that there are a number of potential pathways that can be targeted. The B-cell receptor, PI3 kinase pathways, cell cycle, of course, apoptosis with BCL2 inhibitors, et cetera. So lots of potential targets. We have 4 drugs, 3 in this country, that are approved for relapsed mantle cell, including the proteasome inhibitor bortezomib, lenalidomide, an immunomodulatory agent, and ibrutinib, which is a BTK inhibitor. So I want to look at each of these and without, again, showing you all of the background information, just talk about these are agents that have their single agent activity is very good in the relapse setting. What about moving them earlier in the sequence or combining them with current therapies to get better responses? So lenalidomide, if we consider that first, this is a drug that works in a number of ways. One is that it interrupts cytokine-mediated interaction between tumor and stromal cells. I'll say a few more things about that at the end. So keep in mind that these lymphoma cells aren't just, living and thriving sort of in isolation. They depend upon the microenvironment in a variety of tissues to be nurtured, sustained, to support proliferation. So one of the things this drug does is it interrupts some of those cytokine-mediated interactions. It's immunomodulatory, can improve your innate cellular immunity. When you give it in combination with rituximab, the reason rituximab has activity, it's a naked, unlabeled antibody. It binds to the lymphoma cells and activates via FC receptors, effector cells, T cells, NK cells, to bind and destroy the target. Lenalidomide enhances that synapse and enhances that immune-based killing. So this is just from the data from a few years ago showing that the single-agent activity for rituximab is about a third of patients, but not that many complete remissions, but an active drug. This is a summary slide from work that was in the New England Journal about a year and a half ago from Gio Ruan, who's in John Leonard's group at Cornell. So a small series of older patients, many of them not good candidates for chemotherapy. And what they found is, so with frontline lenalidomide rituximab, they had a 92% response rate. 2/3 of patients achieved a complete remission. So that's certainly up there with any immunochemotherapy regimen. The 2-year progression-free survival, they stayed on sort of a maintenance phase, but the 2-year PFS was 85%, and only 1 patient died during those 2 years. And it also was interesting that we have the MIPI score, which is an IPI prognostic score. And for the fellows and in the group, you have to remember that when you see these prognostic scores, they're relevant only in the context of what treatment was given. So from the standpoint of rituximab or immunochemotherapy, the MIPI score is actually very useful. But and people with high-risk scores do less well with those regimens. But when you're giving a biologically based regimen, the MIPI score kind of goes away, as does the proliferation index. Whether you were low risk or high risk, they responded equally well. So, it changes your perception of what risk means if you have a therapy that can overcome those barriers. Bortezomib, the proteasome inhibitor I mentioned, has, again, about a 30% response rate, only about 8-10% complete responses when given as a single agent in the relapse setting. What if we combine that with one of our standard regimens? So again, this is just the summary slide in a large European study, not done by the Mantle Cell Network, but led by Franco Cavalli, comparing standard rituximab CHOP versus modified CHOP, where the vincristine was taken out and bortezomib was inserted. So that's VR-CAP. So the question is, does inserting bortezomib, an active relapse agent, into the frontline setting provide benefit? And much as Sagar well knows, with myeloma, bringing that into the front line and combining it with therapy, you can see that the progression-free survival was significantly improved, and there was no maintenance therapy given in this study. So if you added maintenance, you may in fact be able to improve this even more. Now there are some side effects with this regimen, neuropathy, and especially thrombocytopenia, that makes it a little more of a challenge to use. But it's a proof of principle in a large study that bringing one of these agents and combining it with a standard backbone, you can improve outcomes. So the U.S. intergroup, this was led by ECOG, Mitchell Smith, led this a randomized phase 2 study with the same idea. So bendamustine rituximab is an active regimen in a variety of indolent lymphomas as well as mantle cell. So this study asked the same question: 6 cycles of bendamustine Ritux versus BR with Velcade or bortezomib added to it. So that was the induction, and then Since rituximab maintenance has become fairly standard, the second part of the study was to look at Ritux maintenance alone or this R-squared lenalidomide rituximab as maintenance. MRD data was collected. This study completed accrual of about 400 patients a few months ago, so we'll have a readout. It'll probably be, another 18 to 24 months, I think, at least, but an important study that may well be practice changing. So, switching gears once again, let's think about some of the exciting agents and approaches that have come into our treatment array for mantle cell and other entities via inhibiting B-cell receptor signaling. So as, of course, many in this group know, a characteristic of most B-cell malignancies is that they have constitutive activation of the B-cell receptor signaling pathway. So this, in normal B cells, an antigen binds to the receptor and it triggers a cascade of signaling through tyrosine kinase enzymes that then phosphorylate substrates and upregulate proliferation. That's what allows us, of course, to generate an immune response. If this is turned on by a variety of mechanisms through mutations in one of these enzymes or through other mechanisms of activation, then these cells are just sort of, they've got an on signal that just keeps them in a proliferative phase. So what if we inhibit one or more of these with a targetable agent, a drug, in this case ibrutinib, which inhibits Bruton's tyrosine kinase? So this, there was very exciting phase 2 data, phase 1/2 data that led to this multi-center phase 2 study that we published in the New England Journal a few years back. Michael Wang from MD Anderson was the lead. So it was patients who either had or had not had prior bortezomib for relapsed disease. The endpoint was overall response rate. The dose was 560 milligrams a day. So median of 3 prior therapies. Most patients were intermediate or high risk disease. So if you look at the first line here in terms of overall response rate, 2 out of 3 patients respond, and it didn't matter if they had failed the proteasome inhibitor or not. But complete remissions only in about 20 to 25%. So good responses, not a lot of complete remissions with single agent. And if you look at the PFS, the orange line is for all patients. Those who had been previously treated with bortezomib maybe did a little better, but not a significant difference. So 2 out of 3 respond. And with a follow-up report that came out a couple of years ago, we showed that about 40% of patients were still in remission at 2 years. And in fact, 2 of the patients that I had on this study, and I'll make a plug that I don't need to make to this audience, but I'll make it anyway, about the value of clinical trials. So, for many patients, as you all know, with especially relapse refractory disease, a clinical trial likely represents their best approach to therapy. And 2 of the patients I had in this study were had very advanced disease and had relapsed. One of them was a patient Bruce Chesson sent because we had the study and it wasn't open at their place. And this gentleman was the last person to get into the trial in the US. He had very advanced disease. He was a retired Navy pilot, tough guy. But he was really debilitated from advanced disease. He had failed multiple therapies, and he got in as the last patient in the study. And within a month, he was back on his boat down at the lake, fishing, riding his motorcycle, which I did make him stop. I said, you've done well. Just sell the bike. So he did. My dad would be proud of me for getting somebody off a motorcycle. But so he is now, in February, he'll be 4 years in remission on this drug. He's tolerated it just fine. He's had no problems at all. So, he's fortunate both in the depth of response and the duration, but it reminds us that, he probably had weeks to live, and he got onto this study, and we all have examples of that. So it reminds us, how important it is to push this work forward, and it also, what I think about are the patients I had who just missed. Like all the people with mantle cell I treated, that, man, if we just had lenalidomide or ibrutinib back, when they were here, they'd still be around. So it gets me motivated every day when I'm coming in that this is this is important work that we all do, and moving this field forward as fast as we can is just really a valuable thing to do. So, very high single-agent response rates, as you all know, but not a lot of complete remission rates. So questions that come out of this are, it's certainly an important advance, but what are the mechanisms of resistance? In the third of patients who didn't respond, why don't we get more complete remissions? A lot of times with these patients, when they progress through treatment, it can be very aggressive. I mean, within a matter of days and weeks, their disease is really taking off. So what are the mechanisms for that? How do we anticipate it and prevent it? What about using combination therapies? What about using MRD to help guide treatment? So we better understand now a lot of the mechanisms of resistance. So basically, the B-cell receptor pathway has both a classical means to signal through a lot of intermediaries to lead to NF-kappa B activation. There are also alternative pathways through the CD40 receptor and through MyD88. So there are various ways and pathways that these cells can activate NF-kappa B. And of course, it's apparent, even in this cartoon, that if you're blocking this pathway, that the cells can escape by upregulating a parallel pathway. So they can get around that single block without a lot of difficulty. So this is a little more detailed version of the same pathway and a very out-of-date version to remind us that, you know, it's not just ibrutinib and BTK. There's now acalabrutinib. There are other ways to target members of this pathway, which I won't read out, except to point out that the proteasome inhibitors and venetoclax turn out to also be very relevant to treatment of mantle cell, but also for combining with ibrutinib, and that's what I'll show you in the final parts of my talk. So venetoclax was a very long in development, very rationally designed inhibitor of BCL2. And the way it works is as a BH3 mimetic to induce apoptosis in cells so it can overcome overexpressed BCL2, which blocks apoptosis, and so these cells survive rather than undergoing normal cell death pathway. You would think that a drug like this should be just a home run for follicular lymphoma, where virtually all of them have BCL2 overexpression, but actually not so much. The purple here are the follicular lymphomas, but actually mantle cell. So these, it was about, it took a high dose and only about half the patients responded. 4 out of 13 overall in this series, but most mantle cell patients responded. We know mantle cell, not by translocation, but by other mechanisms, overexpresses BCL2 at a high level. So here's our cartoon again. There's ibrutinib blocking this. So what we've done in our translational group, so we partnered with Dr. Michael Weber, who's our former Cancer Center director, and he's an international expert in cancer cell signaling, co-discovered MAP kinase, and others. And he's been mostly a melanoma guy and a prostate cancer guy, but he got into lymphoma research as part of a project that we actually got initiated with a fellows research project who wanted to do a lab project, and it's led to a whole other series of work that I'll summarize. So what we wanted to know is, you get mostly partial responses. There's intrinsic resistance, which may occur as a result of autonomous signaling, as well as maybe environmental factors that trigger resistance. And our central hypothesis was that you could identify rational combinations that co-target a driving mutation like BTK and the resistance pathway to overcome this. So one of the things that happens, perhaps, again, just thinking in a very general way about mantle cell lymphoma that responds to ibrutinib and then rapidly progresses, is that there has been an alteration. We call it the, and others, the adaptome. So you're stimulating a response in these cells that allows them to bypass your inhibitor and then break through and clinically progress. So we wanted to look at, can we figure out the smart things to combine with ibrutinib to give better responses? So here's the heat map for our initial studies using a couple of mantle cell lymphoma lines. So we used ibrutinib combined with a variety of agents that I won't read through, but the important ones that showed the big signal of activity were combining it with venetoclax, the BCL2 inhibitor, and with proteasome inhibitors. And here it is in a simple way with showing the response in vitro to each agent, here with carfilzomib and here with venetoclax, and here's the combination. So it's active. So this is a very brief way to say that because of this synergy and because ibrutinib is already approved for mantle cell lymphoma, and there's preliminary data clinically that single agent venetoclax also has high activity, although relatively few complete remissions, in mantle cell lymphoma. So these are two active drugs clinically. There's preclinical rationale. So my colleague, Craig Portell, wrote up this phase 1b trial that's supported by AbbVie to combine ibrutinib and venetoclax. And we started that in late 2015, and I'm pleased that colleagues here at Emory, Jonathan Cohen, is working with Craig on this, as well as another an ECOG trial, but also Brad Call at Washington University and the lymphoma team at City of Hope are also engaged in this study. And here it is. It's a continuous reassessment model testing, since these two drugs really haven't been combined before. In this sort of study, it tests different doses and escalation schema, which I won't go through here, but that's the trial. We've enrolled, I think, 13 patients thus far at all the centers. This reflects a comment I made earlier that, again, these cells don't survive and thrive in isolation. They require a neighborhood and understanding the very complex biology of what helps these cells make it and cause all their problems are cytokines going from stroma, from other immune effector cells. And this this certainly varies from various compartments. Bone marrow and blood are no doubt different from lymph node and spleen. So Kailesh Jayappa, who's a postdoc in the lab, wanted to look at some of the mechanisms that might blunt the ability of even this combination to kill cells. So what he did was to try to create this agonist mix. So the idea is that you in vitro expose the cells, and these are mostly primary tumor cells, mantle cell and CLL. And here's the cleaved PARP, so this is a marker of cell death. So if you look at the blue is CLL and the red are mantle cell cases. So if you look at the cell kill with the combination, it's quite good. If you pre-treat these cells with this CpG oligonucleotide with soluble CD40 ligand and with IL-10, then you can induce nearly complete resistance to that combination in vitro, as shown there. So this is one of the summaries from his presentation, his oral presentation at ASH a couple months ago. So he's looked at NF-kappa B signaling, which gets upregulated by REL-A and REL-B upregulation as part of the resistance. As shown here, this is nuclear expression of REL-B. You can see here when you pre-incubate them with this agonist mix, it gets turned on. And here's an image stream analysis showing the localization into the nucleus in the presence of the agonist mix. So here versus that. So you can show the impact of this effort to reproduce the tissue microenvironment that might allow cells to survive and in fact overcome and show resistance to this combination. So, I didn't show the data, but he's also found alterations in activation of other components of that signaling pathway that we think may also be relevant. So the conclusions from this work is that we see a lot of variability in vitro among these samples. We see that clinically. There have been 2 of the patients on the study so far, including 1 treated here at Emory, that this was a very highly refractory patient here who did not respond to the combination. That this extrinsic factors can mimic signaling through CD40 ligand and others to potentially help or generate resistance, and that perhaps combining this in a different way using an inhibitor, more specifically of the NF-kappa B pathway, may actually make more sense. There are trials now ongoing looking at ibrutinib plus carfilzomib. So where does this leave us in the near term? So in the last 25 years, from around the time that mantle cell lymphoma was initially defined as a specific entity, when, if you look at studies from that time, the median survival was felt to be about 3 years. So it was felt to be one of the worst lymphomas you could get. It combined the characteristics of both aggressive lymphomas in its clinical behavior and like indolent lymphomas in that it was not curable, like, say, large cell lymphoma. That's changed a great deal. We now expect patients to live a decade or longer with the series of therapies that we can do and the better ways we have to generate a good response. So the things that are being tested now, and I think we'll change our therapy over the next few years, are using these maintenance and consolidation strategies. So perhaps somebody who's, as I said, MRD positive after induction, maybe you take them to transplant. If they're not transplant candidates, then perhaps you do an R-squared maintenance, or you do a proteasome inhibitor-based therapy to try to get that deep response and then maintain it. I really think we'll be able to get more standardization of our MRD assays so that you can start to do preemptive therapy, as has already been piloted by the Nordic group. We're going to see more and more of the examples of the novel combinations, so the R-chemo plus a targeted drug, or just non-cytotoxic combinations. You saw a couple of those. I think we'll be able to have a better idea, perhaps through molecular markers, or to know how to sequence therapies for people who do relapse. We'll be seeing doublets, non-cytotoxic induction, and I think over time, there will be less reliance on very dose-intensive therapies as we get smarter and smarter weapons and learn how to deploy them to control the disease. So our team at Virginia has been expanding. We have our clinical research team. This is Mike Weber and Craig Portell here. These are our bioinformatics folks. There's Kyle Brett, who's our fellow with, it's not Violet, I think. So that's her daughter. And this is Melanie Rutkowski. Is Nico here? Can I see her? Anyway, we're very interested in collaborating with the group here on the microbiome and the influence it has on mantle cell development. So we shared some email exchanges, and we're going to look forward to those collaborations. So it's a good team. This is most of the crew right here. But I want to just close also by, again, thanking the Puri family for supporting this. It's really been a spectacular couple of days for me. I've learned a lot, and I'm very energized and excited by the collaborative opportunities that I have. And I want to thank Barbara for masterful organization of everything, and she carries it all off in an incredibly delightful way. So even when she needs you to do something or to get it back to you in a hurry, you don't feel put upon. That's a great skill and a valuable part of the team. And I want to also thank Dr. Flowers, Dr. Loniel, and everybody on in the group here who took time out of, I know, very busy days to have meetings yesterday and today and to go over things and to share their work and to explore ways that we can collaborate. So again, my thanks for making all that possible. Thank you very much.